Welcome to Coffee with Kyle number 10. I'm Kyle Ridgway. Good morning. Got a little French press this morning, made it myself. I think Kenny Veneer will be proud of that. Ground the beans, heated the water, did the French press. So no cafeteria coffee for me here on Saturday. Today I wanted to talk a bit about the legacy of critical illness in post-intensive care unit syndrome, and then kind of dive into the details of that a little bit on how it can maybe help with critical thinking a little bit. So for those of you who are not aware, when patients get medically sick, we can look at different organ failure, different multi-system organ failure, or single system organ failure. And, in critical care, our physician, nursing, pharmacy, respiratory colleagues are highly specialized and focused on stabilizing the vital organ systems, lungs, liver, kidneys, heart, right? And what we've actually found over the past especially 10 to 20 years when researching patients who live, because when you get critically ill, especially medically sick, these aren't patients who have had necessarily a burn, a surgery, a stroke, or things of that nature, or a trauma, although those patients can get critically ill. But if you think of patients who are medically critically ill, what we found is that the patients who do survive this high mortality, very critical situation, is they actually leave the hospital, and for not just weeks or months, but months to years to even greater than 5 or 8 years, exhibit remarkable neuromuscular, cognitive, psychological, and functional impairments, deficits, and problems. So much so that when I have student interns or physical therapists that I'm mentoring in critical care and rehabbing patients after a critical illness course, is I tell them, I say, look at some of these outcomes articles that track people who have been very critically ill and strip away the diagnoses, and what type of population does it look like? And these look like patients who have maybe had a profound neurologic event, had a brain injury, had a very significant trauma that may have affected them psychologically and physically. And so what we found is that our conceptualization of organ failure probably needs to expand. In other words, even though your lungs, liver, kidneys, heart may fail, acutely even, your nerves may fail, ICU acquired weakness. Your muscles may fail, critical illness myopathy. Again, to the nerves, critical illness polyneuropathy. You may have what some people call brain failure, which I think is a great way to categorize delirium. You may have physical functional failure. You are no longer independent. Once you get out of the hospital, these issues persist, and they're unpaired from some of the medical issues. And what I mean by that is that if you look at patients who have acute respiratory distress syndrome, ARDS, which is a very high mortality, serious lung issue, about 50% mortality worldwide for patients who have severe ARDS. Those patients have remarkable inability to return to work. Their 6-minute walk test 5 minutes after ICU or 5 years after ICU discharge may only be about 65 to 70% of age-predicted norms. They report depressive symptoms, anxiety, a prolonged physical recovery. Some are actually even diagnosed with PTSD, an actual major depressive disorder. But those are not paired with their pulmonary impairments. So what I mean by that is if you look at someone's pulmonary impairments, their pulmonary function tests or other tests of pulmonary function, those impairments are on average relatively mild and relatively stable, so that the impairments that we're seeing physically and functionally can't really be explained necessarily by lasting pulmonary impairments. And so what we've kind of found is that the sequelae of critical illness, of surviving critical illness, is really profound. So much so that even families may be affected. Families may suffer complicated grief, which kind of makes sense, right? Quite frankly, if you have a family member in the ICU who dies, that's kind of an event that happens. Psychologically, you can maybe start the grieving process or the coping process and work through that. If you have a family member in the ICU that is always on the cusp of dying, they get close, they're revived, they're getting better, then they get worse, and they end up surviving, and they have all these impairments and all these problems that maybe no one really talked to you about, no one expected, or that you didn't expect your family member to have, you may actually have complicated grief because now you have a new family member, you have a new person, you have to help take care of them, they can't go back to work. So that can be very, very distressing, very distressing. And because of this, researchers kind of came up with this conceptualization called post-intensive care syndrome. And they kind of have one arm of it that deals with issues that the family may deal with, and those are a lot of times mental health issues. And then they kind of have three constructs at the patient level as far as issues that patients have after an ICU course, or really a critical illness course. And they kind of break it down into mental health issues, physical issues, and cognitive issues. And some of the things that fall underneath that are, obviously you can have some pulmonary impairments, neuromuscular weakness, or just diagnosable weakness, physical functional impairment, ADL impairment. At the cognitive side, you can have problems with visual, spatial processing, memory, executive function. Mental health-wise, you can have symptoms of anxiety and depression, post-traumatic stress, but you can also have the actual psychological diagnoses of major depressive disorder, anxiety disorders, and post-traumatic stress disorder. So what we found is that critical illness is really actually a profound, multi-system, whole body, whole social support trauma. And because of that, there's been a lot of focus on, can we maybe prevent some of the sequelae that happen with a critical illness by intervening with certain bundles of care, certain rehabilitation principles early on in someone's intensive care unit stay. And what I've kind of found, or what my sense has been working with patients like this, is that some of these issues may be preventable, but all of them are definitely not. And I think that's for a handful of reasons. And I think the first one is that the critical illness itself imparts significant damage to the entire person, from psychology down to physiology, across all systems, that even with the best treatment cannot be prevented. Secondarily, the way that we have to treat critical illness, both medication-wise, intervention-wise, as well as environmentally, I think kind of sets up and facilitates or contributes to some of the issues that patients develop. Now, some of these things may actually be modifiable. Sedation practices, wakefulness practices, mobility practices, orientation practices, communication practices. Some of these things may actually be able to kind of block or stave off some of these effects. But again, not fully, I don't think. And so really, I think the way that we need to look at treating a survivor of critical illness or someone who's critically ill is, there's been a lot of focus within the ICU, which is great. But I think we'd be remiss to assume that putting all our resources in the ICU in terms of prevention and treatment is going to impart the long-term impact that we want at 3 months, 6 months, a year, 5 years, 10 years after an ICU course. And the reason that is that if we're going to put all our eggs in the ICU basket, we've made a potentially an error in thinking, or at least an assumption. And that assumption is that these effects that we're seeing downstream are all because of modifiable risk factors or things that we can prevent. And I think some of the newer research that is actually looking at early intensive therapy in the ICU, wakefulness practices, mobilizing patients early and often, kind of shows that even though it's safe and it's feasible, it may improve short-term outcomes, that this isn't necessarily robustly changing people's outcomes at 3 to 6 months in a year. And what that suggests is not that we shouldn't see people in the ICU and be doing what we're doing and advocating for that, but rather that that's likely not enough. And the example that I like to use that's pretty salient to me is, if you think about other segments of rehabilitation or other diagnoses that have pretty profound multi-system functional cognitive effects, such as like a stroke. You take someone who has a massive right MCA stroke. No one would ever assume that front-loading care in the ICU is going to take care of all their long-term problems, right? There's a continuum of rehabilitation, a continuum of medical and supportive and psychological and counseling care that crosses the continuum all the way into community programs. And that's the way that I think we should conceptualize critical illness and treating critical illness survivors. The thing that I want to dive into for critical thinking, and the thing where I get justifiably, I think, a little nervous reading some of the research is, I'll read editorials, saying very what I would say very imprecise statements such as, can early mobility prevent PICS, post-intensive care unit syndrome? Well, first of all, again, that's on the assumption that all of these acquired disabilities and acquired impairments are preventable and are because of modifiable risk factors, which again, there for sure are some: immobility, over-sedation, lack of communication training for patients who, or for providers who communicate with patients who are mechanically ventilated, but that's not enough. The other problem is if you look at, and I will put in the comments a picture, a schematic of PICS, to think that a singular intervention or intervention package is going to prevent all of the problems that underlay the PICS umbrella, I think quite frankly is a little ridiculous. I mean, we're talking about ICU-acquired weakness, critical illness myopathy, critical illness polyneuropathy, depression, anxiety, inability to return to work, 6-minute walk times that are slower, cognitive dysfunction in multiple domains: visual, spatial, executive function, memory, problem solving. To think that there's single interventions that could prevent all of that, again, I think we're making an error in not going deep enough into the details. The flip side is I think the name of it, post-intensive care syndrome, actually leads us down this inappropriate thinking and problem-solving route. And the reason is a syndrome is actually a cluster of clinical signs and symptoms, right? It's not a physiologic diagnosis. Those are different. I actually think that we've mislabeled post-intensive care syndrome. And I don't want people to conflate that I don't like it or I think it's harmful. I think it's been highly beneficial to have this term to kind of cohese all of critical illness survivors and families' problems into kind of an easy kind of saying. But the problem is that under the PICS umbrella are actual diagnoses. Critical illness polyneuropathy is a diagnosis. Critical illness myopathy is a diagnosis. Post-traumatic stress disorder is a diagnosis. Depression, major depressive disorder, is a diagnosis. So at least the way that I understand syndrome construction is you can't have a syndrome that actually contains medical diagnoses. So I think we've made a really big error there, and we could continue to make errors in both research and clinical practice by asking questions such as, does X treatment prevent PICS? Does X treatment remediate PICS once someone has it? And the problem here is if you take two patients who have PICS, one could have mostly, let's say, cognitive and mental health issues. They have signs of depression, they have some anxiety, and they have a diagnosable post-traumatic stress disorder, and they have cognitive dysfunction, impaired executive function, impaired short-term memory, things of that nature. Physical function is maybe mildly impaired. Nerves and muscles are working okay. Well, then you could have someone who psychologically is okay, maybe a touch of anxiety, but otherwise no diagnosable problems. Cognitive dysfunction may be mildly impaired, but they're physically and functionally remarkably impaired. They have a critical illness polyneuromyopathy, profound weakness, maybe acquired dependence, inability to walk. We would be remiss to think that the treatment for these two patients is completely different, or is the same rather. It's completely different. We need to have totally different treatment paradigms and approaches for these people. So what we need to do is we need to continue to classify and track the problems that patients have acutely, the problems that patients have in kind of an intermediate subacute stage, and the issues that patients have long term. And we need to continue to see how those are related and interacting. Does psychological function correlate with physical function, and does improvement in one or the other correlate with improvement in the other? For example, we improve psychological symptoms and patients' physical function improves, or we improve physical function and patients' psychological symptoms improve without treating the other one. And then we need to also continue, I think, to work acutely to identify what are the either acute environmental treatment or diagnostic physiologic variables that seem to either causally contribute or correlate with some of these issues acutely and long term, and are there modifiable risk factors that we can modify and affect either acutely or long term patients' outcomes. But then again, for a continuum of care, we need to pair interventions that are either well researched or plausibly postulated to affect the problems that patients have. And we can do this at a group level, of course. So if we take groups like patients who are mildly cognitively impaired but significantly physically impaired. How should we treat them versus patients who are significantly cognitively and psychologically impaired but minimally physically impaired? How should we treat them? But then we really have to dive into the weeds, I think, unfortunately, and for each patient, come up with a care continuum and specific interventions and providers and professionals that are best suited to address the specific issues that that specific patient has. Because I think, quite frankly, the presentations are very variable, but they're very profound. And I think it's going to take a remarkable team to rally around this patient population as they travel through the continuum of care. And I think we can learn some things. Critical care, people who work in critical care or work with patients who have survived critical illness, from intensivists to nurses, respiratory therapists, physical therapists, occupational therapists, speech therapists, counselors, chaplains, all of us who work with this population. We can learn from, I think, neurologic rehabilitation, especially specialty rehab hospitals like hospitals that specialize in spinal cord injury and traumatic brain injury rehabilitation. We can learn from oncology rehab, because I think that's one that has the medical severity and high mortality issues that we see in critical care. We can learn a lot about the concept of prospective surveillance, the concept of, not just living, but how do we empower survivorship. And I think we can also learn from the concepts of cardiac and pulmonary rehabilitation for patients who have had acute and chronic cardiovascular and pulmonary issues. And so I think if we, again, put our lens outward, which I've spoken about before, there's a lot to learn there. Because Paul Wishmeyer, who works at Duke, he's an intensivist and very into nutrition, he wrote a nice editorial, and it was entitled, and it really kind of hooked me because it was so powerful. He said, are we creating survivors of critical illness, or are we creating victims of critical illness? And I think that's something really important to think about as we're working with this population. But from a thinking standpoint, I think we need to be much more specific in our language and how we're assessing problems, and understanding that post-intensive care syndrome is probably a great term to use with the press and with patients and with families, but that term itself isn't necessarily going to help guide research or clinical practice. We have to go to the next layer of what are all the problems that live underneath there, and how do we bucket them into groups or individually address them. So I think that's all I've got for us this morning. It was good to see you, and have a nice day.